Neurovascular Intervention at Medicover Hospital, Visakhapatnam. Today we have a complex situation where we have a 55-year man who is having very atherosclerotic aorta, and the aorta which has given rise to an aneurysm. So aorta means heart nunchi manchi rakta teesini blood vessel ki we call it as an aorta. Aorta is the largest blood vessel in the body which starts from the heart, and it is responsible for supplying blood to brain, hand, legs, abdomen, thorax. Prati organ ki blood తీసానికి ఈ aorta is responsible. Abdominal portion లో పొట్ట దగ్గరే ఈ aneurysm develop అయింది. Let's go and see the image, we'll understand better. So this is the heart. Heart నుంచి మేజర్ బ్లడ్ వెసల్ వస్తుంది. ఈ మేజర్ బ్లడ్ వెసల్ పొట్ట దగ్గరే at the level of the abdomen there is an aneurysm that has developed. That's the reason complain of severe abdomen pain. This pain is not responding to any kind of medication. That's why we want. So this is the aneurysm from all sides which we are going to treat. Chalo. Got it, come. So Rohit, you want to give some input? That's good. Okay, chalo, come. So we will do a total percutaneous. Can you show me? La 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 la. What? Table down a bit. Yeah. So we will deploy two proglides, one at 10 o'clock, one at 2 o'clock, and hold, gently hold. Slow now. So very useful device, this proglide. So we're deploying it at 10 o'clock, this one. Give me the mosquito. Light here, beta, light here. So we'll put one more proglide. So always maintain your axis basically. So Gauri is helping here on my left, on my right we have Parvati. Tight, hold tight. Throw it out. So we'll put a second proglide. So these are like a suture which are done before the procedure. So this is pre-closure, and in case we need we can always put another one as a post at the level of 12. So you go take it straight and then go inside, and you should see the blood flow freely like this, and then you rotate it at 2 o'clock, and then you can take the hinge off, and exactly at 2 o'clock, and then you deploy the suture relax the pedal and harvest the suture and put your wet gauze on the suture so that they are not dried up, and maintain the 10 o'clock and 2 o'clock. Hold it tight, hold it tight. wire they? J wire, short wire. So they give it to me, not required. So you should have the suture well placed all the time. Now, once the suture is gone, use both your hands, Gauri. Use both your hands. Very nice. Leave the seat. Yes. So it's a 11 French device that we are going to use to repair this aortic aneurysm today. So it's a Medtronic Endurance that we'll be using. So you can see it's very nice, and you can see the free flow of blood. Don't show blood, Baba Sinu. Okay. We have stylist Sinu, who is behind the camera, who looks very excited today. What about the dinner? You can just, Prasad, can you do the needful? Prasad. Yeah. You should say okay, not okay, whatever it is. Where is Sujit Bhai? Sujit Bhai, please take some opinion how the patient presented and all that. Dr. Sujit, our cardiac surgeon, he will tell us how the patient presented to us. Right? Is Dr. Sujit, our cardiac surgeon. Please tell us how the patient presented. What are the symptoms?
Actually, patient having some abdominal pain. So he is a known case of CKD. Then he present consult with nephrologist and did ultrasound and find out that there is a swelling and it is suspected as aneurysm, abdominal aortic aneurysm. So we saw the patient, make it stable. Then CT angio done. It is found that there is a large circular aneurysm, which is mostly will be succeeded by the endovascular stenting. Next, we also did that is echo, heart little weak, is not fit for surgery.
Exactly.
So we hope we'll do success. Dr. Dalai will definitely do it.
So let's go ahead. And so we have seen that aneurysm. So another look at this aneurysm, which is looking very, very fragile. So unless you treat them really good and really early, then you might actually have this aneurysm ruptured and might lose the patient. Okay, na? Keep compressing a little bit. So give me a watt and Terimo. Go ahead. Very nice. Stable. So you can see this aneurysm is bending the whole thing. Table, please. Table, please. So we have Prasad, our chief technologist, and we have Dr. Pavani, who is a super good neurovascular anesthetist and plus super stiff exchange. We have Rohit from Medtronic. Tell me. We'll take the pigtail. Yeah. So hold us. Absolutely. Very good. Exactly. Give me the pigtail here. The injector is ready.
This pigtail also, sir.
Any pigtail is okay. Among their marking pigtail. So generally for abdominal aortic aneurysm, which is large, we do a kind of, we do a bifurcation stent, which is in a common term we call it as a pajama stent and all. But here we have a different set of challenge. The aorta is very tortuous, and this is about 7 centimeter from the left renal artery, and our device, the smallest device, is again 7 centimeter. So we will have a challenge to really accommodate the whole thing. precisely help me with the clip my notes. Yeah. Thank you. So this is going to be some challenge. Looks like Parvati is in a good mood, so hopefully we can do it well and do it fast. Stepping. So we are at the level of the aorta, table pitch. Descending thoracic aorta, we are at the level of that. Okay. Table. Heavily calcified. Mag taku, very minimum mag. Yeah, exactly. हाथ निकाल दो. Take your hands off, Gauri. Yeah. Perfect. Wonderful. So we will go ahead and do an injector ready. We are not going to inject a lot of contrast because the patient is having CKD. So we will do minimal contrast uses here. So what are the presentation of abdominal aortic aneurysm generally?
Most of time patient will say there is a pulsation, abdominal pulsation, and there is pain because this circular energy compressing the other structure. Patient feel nausea, other abdominal symptoms.
Abdominal symptoms will be there.
It is anteriorly present.
Exactly.
And it is very big size, and there is lot of clot is there.
Yeah, it's like the intact aneurysm is about 7.5 centimeter, which is quite large, and if you just have to include the thrombus, and that's even larger because it's a partially thrombosed aneurysm. 20 ml per second, volume 20, yeah, 600 psi. I'll request for apnea, Dr. Pavani. Are you ready, Prasad? Prasad, are you ready? Apnea, please. Inject. Ventilate. Okay. Stop it. We can keep it for later. Can I have the screen closer to me? इसको stabilize करो. So Prasad, can I have the screen closer to me? Very close to me. Very close to me. Exactly. Keep running. Keep running. Where is the left renal?
Is 4 centimeter from that?
Yeah, we will see. No problem. Can you give me a cobra? A regular cobra with thermo. We will try to cannulate the left renal and do a small injection so that we are very sure where the left renal is. Right renal is not there. Rest of things looks okay.
Somewhere at the third marker.
Somewhere at the third marker. Yeah, approximately. Yeah. CT whites. So quite distorted anatomy. Yeah. Cobra Terimo. You can leave it now. Yeah, this is good actually. You got done a good job. This is how we have to place. Chalo. Go. So we will try to just cannulate. Yeah. So you see how distorted it is. Really, really difficult anatomy. Max Mag de. Table lock. So it's not going to be easy. So we'll try to locate the left renal. Can I have the screen closer to me, further closer? It's so difficult to do anything in this patient basically because of this distorted anatomy. Ammagaru, terimode. So I have quite some challenge to really manipulate my catheter. Prasad, all okay? So this is most likely the left renal. Because of a lot of tortuosity at the proximal, you can have these challenges where I really find this catheter to be really, really tough for me. So in such situation, what we do? What we do is we can put a sheath, a 7 French sheath or terimo, which will straighten and help us understand the anatomy. And because cannulating the left renal will be giving us a lot of confidence. So here I have a lot of challenge to push it. Can you give me a Terimo 7F short sheath, 35 centimeter? So once we put a sheath and straighten this proximal axis, then we'll be able to take a cobra and let's understand that what is the level of the left renal. Exactly. So we have to let us look at which vertebral level we have this renal coming. Left renal at what vertebral level? Huh? L2. Can you show me the left renal? Where is the left renal? Show me. That's the left renal?
Yes.
L2 upper border?
L2 upper border.
Oh.
And it is stenosed.
Yeah, it's table. Table please. Prasad, table please.
Sorry.
Table please. कौन कौन बेटा प्रसाद एम చెప్పండి 7 French नहीं 6 French ఇవ్వండి 6 French is the best 6 French and 35 centimeter because we have to do a diagnostic angiogram. For that I just need to straighten the proximal axis. Yeah. Okay. So we'll straighten the proximal segment. That will give us a lot of comfort in terms of doing a left renal angiogram. Table pitch. So this intermediate length sheath, which we will navigate up to the aortic bifurcation or maybe to the common iliac, even we can take it to the proximal aorta, which will give a lot of stability. So once it gives the stability, we can take the cobra and we can finish off the left renal angio. And so basically, as we always discuss, that there will be challenges when you are doing difficult cases. So you should always have your plan ready. So you see, we just have parked our sheath. Now we will take a cobra inside it with a telimo. So this is a good teaching point here, that instead of struggling there, you have to move on to the plan B. Back, wire back. Bharat, are you okay? You are looking little tense today, I mean. Program unda, marriage program. Yeah, అయింది కదా ఇప్పుడు. లే. Focus here, can you give me some flush? Table, please. So yeah, so it's quite tortuous. Should you be giving me a black cobra? Yeah, we can see the renal here. You can apnea, please. Stay away. See the renal? Okay. Ventilate. So the renal is very stenosed, which we will deal it with later, as we have discussed. Aja beta, aja. Ventilate. So you can see, Baba, Srinu, Prasad, stop. You can see it's a very difficult case because you have very tortuous anatomy, the renal is tight. So today, once we put the stent and do everything well, then we will come back and we will do an angioplasty and put a stent, because we don't have a renal on the other side. And this renal is very critically stenosed, almost like a 90% stenosis, single renal artery, which will stent in the phase 2. Before discharge, we will put a stent, do an angioplasty and take care of it. So, but today, the program is to put the stent graft right from here down. So, if we measure 1, 2, 3, 4, 5, 6, 7. So, our stent graft will exactly end at the level of bifurcation. That's the plan. Help me with the mask. You. So, that's what is the plan. So, I think we are very clear. So, this kind of difficult situation can be there. थोड़ा पीछे इसको पीछे थोड़ा ऊपर कर दे इसको. हाँ ओपन చేసి कुछ पाई नहीं एग्जैक्टली. देख लेते भाई, it's a critical stenosis.
Also
So by
stenosis,
by
they are
taking
in
care of the
an-
stenosis, even the creatine level will improve further because the renal function will improve.
And there is also stenosis in the SMA.
Yeah, SMA as well as the left renal. So now, give me the Terimo. So lock that table here. So we will just have to put the graft here. Now give me the Terimo. We'll go up and then we will take the land quest. So it's a very, very important lesson. Hold, ma, hold. Very, very important lesson for understanding this scenario. Table please. Okay, wait. Table locked, na? Table please. नहीं, one more injection में वो दिखना मुश्किल है. The ladder quest दे, हाँ? Land request. Show me the last one and keep it as a native. Yeah. So this is the last strip, that's a 12th strip. This is the first, and this is in between the first and the second. So if you deploy the stent graft from the second vertebra upper border onwards, then you will be right. You save this image here. You save the 12th, save the image here. This is the 12th rib. This is the first vertebra L1. This is the L2. So the left renal is between L1 and L2. Our focus will be to start the graft from the L2 down. L2 upper border. So we have our land quest ready. Leave it for this one. So we will prepare our graft. So we are taking an endurance 28, 28, 70. Chalo.
How much?
3000 happened here.
Given.
No, no. So this is Endurant from Medtronic. Very, very precise device. Bye. Up.
Have a solution.
So it's an 8 French system, low profile. Hold it. I will take out the seat. Right. The table, please. All right. Table, please. All right. So we are trying to make use of the anatomic landmarks and avoid a lot of contrast. So we just engage it slowly and try and go inside. Give me the blade, 11. She's got good skin. 11. So it's important that we do it at 12. Skin is very tough. Nice. It's very smooth. Paro, what is the plan? The food is ordered or not here? What is the size here? Baba? What? 70, yeah? Looks so small. Table? All right. So, can you mark it? You have a marker? Marker? Marker. Come. So this is the 12th. See this? That's the 12th rib. Then between 1 and 2. So 2 upper border. Yeah, that is 12. 1 and 2. Upper border. Yeah. Niche. No. Exactly. Yeah. Yeah. That's where we should be deploying. Okay? One injection will do, but we are taking care of the whole thing by multiple ways. First we are taking care of the bony landmark, then we can do an injection and see also. But I have one small injection. Are you ready, Prasad? Yeah. Go ahead, Prasad. Just a little. Go ahead, Prasad. Go ahead. Yeah. Aspirate a bit. Exactly. Perfect. Table, please. Wait a minute. Table, please. Paro. Change the marker. Put it between L1 and L2. L2 upper border. Yeah, L1, L2 upper border. No, be careful. L2 upper border. Pine. Go up. Yeah, exactly. Go slowly like a gentleman. Yeah. Don't be in a hurry or harsh. Okay. Are you ready? Dr. Pavni, are you ready? Baba, team anesthesia. Apnea, please. Inject. Okay. Ventilate. You understand better? That's why I told there is no meaning doing this angio. We have done a selective injection. We have found that it is between L1 and L2 and we just have to deploy it. That's all. You cannot do anything about this in this angiogram because it's a very stenosed small renal artery. Don't think that it will just feel like a highway and we will just get all the clues. Okay? So we'll go ahead. Holding. No? So now we should ensure that where is the E? Exactly. How is the blood pressure, ba? 120/90. See, the E is going exactly where we want it. So it has 4 markers basically: endurance, 3 radiopac marker, 1 E. We are very slow. We have all the time in the world. And you can see this marker there, and if you are at the edge of the upper border, you are perfectly fine there. So always use all the tools that you have. God has given you sensory tools of different type. So no need to force a patient with a high creatinine multiple angiogram to understand, rather use your mind, use your brain, use your eyes to understand.
wanted 1 or 2 mm below.
ଆଉ କାହିଁକି ବିଲୋ ରେ ପୁଅ ଏନ୍ଦୁକୁ ବିଲୋ why ବିଲୋ ବେଶୀ ବିଲୋ କଲେ ବିଲୁଆ ହେଇଯିବ ରେ ବାପା ज़्यादा बिलो नहीं करना it should be very precise okay हाँ 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 as you wish and then we will release the nose cone by moving it clockwise. So it has perfectly come where we wanted, and the nose cone is released beautifully. Now we will do an angiogram and see what we have achieved so far. Better ready? One mag. One more mag. One more. Okay. Table. Okay. Screen हटा दीजिए वो light. I'll request for apnea once more. All right. Apnea, please. Ventilate. Sorry. We will just give it a little time. Apnea, please. Inject. Very nice. Ventilate. Okay. So it's very nicely placed. Excellent. If you want, you can do a little bit of balloon, otherwise that's okay because the fabric will take care. So now you see the renal is also feeling well. Now you can see the renal. I'll show you exactly. Stop. Show the renal. Yes. Very good. So the renal is filling, graft is across, and everything looks so well and beautifully placed, and we are quite above the bifurcation as well. Right. Do you have a coda balloon? You have? Ah, just really good. So you have seen that how precisely the stent graft was placed across this aneurysm, and the renal was well preserved in a very difficult anatomy. It was very difficult to first understand where the renal is coming from, and then the whole thing. So we'll try to capture and bring the device a little bit. So I'll push the nose cone up, and here we will try to capture it. So we are trying to capture, and we are happily coming there. So take it above the fabrics, that's ideal, which we have done, and then you can take your so this is ideal. This is how you have to do. So it's a little bit of challenge here. This is how you have to capture, and so let us keep it here. Beta? So 12 French system. Take it. So we'll take a coda a little bit, we'll do a plastic. So you have to be careful here. I'll take it out, I'll put the balloon. Okay na? थोड़ा सा challenge रहेगा. This is 11 French, 12.
Sir, 11 French.
Oh, this is a 12 French system. So directly pushing. Holding, Gauri. So we'll try to do a little bit of balloon. Very nice. Good hold. So you can see that the aneurysm has been treated and so in terms of challenge, you can have challenge anywhere, and here in this case also you can see there's multiple issues here. There's a lot of. Should I discard? Give me the balloon quickly. Paro, what are you doing? Give me the balloon quickly. Ready कौन बे? फटाफट तो दबो काम सारी जीवा. Yeah. So we'll put this balloon and we'll try to just gently inflate. Inflator ready? Very nice. Slow. No.
You want to take out the pigtail and then
Yeah, we will take out the pigtail. Then we'll put it through the center. Hold very tight. Give me the tail remote. So we'll take out the pigtail and put it in the center of the graft after the plasty. That's where we will leave it for the time being. And now, can you just inflate a little bit? The balloon to be inflated. You're holding it tight. Okay, na? Yeah. Huh?
hand injection.
Hand injection कर दो बेटा. दे. Saline दे.
prevent endolymph.
हाँ भाई यार थोड़ा सा.
To prevent endolymph.
Yeah. पारो गोरिट थोड़ा सा रिलीज कर.
Calcified. That's why.
या अपोजिशन के लिए थोड़ा सा अच्छा हो जाएगा. थोड़ा सा. Enough. So now this should be okay. So now what we'll do is we will come a little proximal. Meet a village. Yeah. So very slow and gentle inflation you should do, because this is not something you should be really working hard on. So now we will close this per close. Wire undali, wire push cheyandi ma, thoda sa wire push cheyandi. Slow. Stop, paro stop. Paro stop. Exactly. Hello now. Just thoda sa. Hold it. So Gauri has been doing a good job.
You can stitch.
Yeah, we will stitch it. We'll stitch it. बंद हो गया. अच्छा.
black. Not push.
So it's a good hemostasis we are getting. Release, Gauri, release. Yeah, it's a good one. पूरा रिलीज कर दो, पूरा रिलीज कर दो. या बंद हो गया. Closed. So hold it, Gauri. No, the wire like this. I am holding. Idiko. The roll chesi, roll cheyandi. Finger roll cheyandi. Ah, very good. Give me some space. So I will just close the knot here one side. Then after taking the wire, we can. So it's a knot pusher and it's nicely done. Wire is out. You can see this. The graft is sitting there right at the level of L2. This is 12, L1, upper border of the L2. You have the left renal artery coming over there, and everything looks so perfectly okay. Thank God.
Done, na?
Just a minute. So now we will lock this one. Gauri, release. Yeah. So we have pushed this knot also at the level of the vessel wall, and then waiting. Yeah. So just little compression. Meanwhile, we can just do the injection and see what is happening. So you might have some challenge here, but not a problem. So, yes, thank God. So we will go ahead with the last angiogram here to understand what is happening. Baba Srinu, what to soy jai na kon yaar. Srinu is quite enthusiastic. But Prasad, one last one. Yeah. Thank you. Good, na? So good work by Gauri, Parvati, Prasad, and of course excellent photography by stylist Sinu, and a great presence by Sujit Bhai, our cardiac surgeon, and of course Rohit is doing a great work. Are you ready? No, quite ready. No, only 28 ml is there. No. Don't do that. That's not right. Add up some 20 ml more. So let us, by the time Prasad gets ready. Hi, Dr. Archana, my little sister is there. She is replacing Dr. Pavani from anesthesia side. No, thank you, bhai. Sujit Bhai is going to attend a marriage, so he's in a hurry. So let us sum up what we have done. Basically, we have a patient who is 55 years who came to us with a very tortuous aorta and a very calcified atherosclerotic aorta and having an aneurysm in the abdominal aorta, severe pain abdomen. That's what he came with. And severe pain abdomen was evaluated, found to have an aneurysm. We decided to do a total percutaneous closure of this aneurysm. We took two sutures, two proglides at 10 o'clock and 2 o'clock, and the access the system. We deployed a graft and looks good. We did a little bit of angioplasty with a coda. Then we closed the sutures very well, and now we will do a check angiogram, and if everything good, we will stop. So far so good. Hemodynamically, anesthesia wise, patient is doing perfectly fine. Angiographically, the images looks okay, we will see how it looks like in the final angiogram.
Disconnected.
Okay, beta, that's enough. That's enough. That's enough. That's enough. That's enough. Wait. थोड़ा सा इसको ले लो syringe bite పెట్టండి right correct wonderful go ahead. Yeah, perfectly okay. So we are ready for the last angiogram, most likely. Team anesthesia ready? Apnea, please. Inject. Wow, this is beautiful. You can see all the endoleaks are gone, and you were seeing some flow through the fabrics into the aneurysm after the deployment of the stent graft, and we did a little bit of coda, opposed the graft onto the wall, and now the aneurysm is completely thrombosed. Everything looks perfectly fine, and the patient is doing perfectly okay. The puncture site is fine, the total Percutaneous closure is good, and everything looks so good, thank God. And thank you all for joining for this interesting case. We will see you soon later next time. Thank you.